Good morning, everybody. I'm Dr. Abideen, one of the pediatric trained from UK. I was one of the team who did this scientific work. I'm very glad to be here and very much thankful to organizing committee and scientific committee for giving me opportunity to present this work here. My topic of the day is role of extracorporeal membrane oxygenation in neonatal myocardial infarction. This presentation is unique and interesting because of few reasons. Because myocardial infarction is one of the common conditions in adult population, but it is very rare condition in newborn babies. And moreover, the mortality is very high. Apart from this, we are using one of the most advanced technology in the management of neonatal myocardial infarction. So briefly, I will talk about neonatal myocardial infarction. As I mentioned, it is very rare in newborn babies. Regarding the cause of neonatal myocardial infarction, most of the causes are congenital heart disease or congenital anomalies of coronary arteries like Al-Kappa. Apart from this, there are very rare causes like perinatal asphyxia or thromboembolic phenomenon or some other idiopathic cause. All the patients I am presenting here is more unique because all these patients did not have any congenital heart disease or any congenital anomalies of coronary arteries. How does the neonatal myocardial infarction present? Most commonly it presents as severe cardiac failure or cardiogenic shock or cardiac arrest. One of the differential diagnoses is inborn errors of metabolism or sepsis. Again, regarding the management, most of the time medical therapy like support the patient with optimum dose of inotropic agent like adrenaline, dopamine or enoximab. Again, mortality is very high. Sometimes it is very difficult to diagnose, even if you diagnose with medical therapy, mortality is very high. So, question is there any need for new approach in the management of neonatal myocardial infarction? Considering the high mortality and low survival rate with the present system of management, I think there is a role for new approach, new method. So, is the ECMO is the answer? Again, it is not the final answer, and ECMO is the treatment method, but it is one of the supportive methods. So, my answer is because of few reasons. I think ECMO is one of the answer to support babies with this sort of condition when they are struggling to survive. Because number one, the literature said the immature myocardium recover from perfusion injury in better way. Compared to adult myocardium, newborn myocardium is immature. So if we support that myocardium during the transient period with support like extracorporeal membrane oxygenation, the baby will recover from the injury and they can survive. Again, there are reported cases in the past in the literature where ECMO has been used for the management of babies with neonatal myocardial infarction. And another evidence is our experience in our ECMO center for last 2 years. We have used extracorporeal membrane oxygenation for the management of neonatal myocardial infarction. I'll just go through the experience we had. Patient 1 was a term newborn, presented at 11 days of age with severe shock. blood investigation was showing severe metabolic acidosis and troponin T was mildly elevated. The baby's metabolic, septic and thrombotic screen were normal. We did ECG. ECG was showing Q wave in lead 1 to V4 to V6, upright T wave in V1 and very poor RY progression consistent with anterolateral infarction. Same patient echo showing dilated left atrium and globally impaired left ventricular function with elevation of pulmonary artery pressure and severe mitral regurgitation. So we have supported that patient with medical therapy like adrenaline, dopamine and enoxaparin. In view of refractory cardiogenic shock, we had to start VA ECMO. On 6th day of admission, the patient, while on ECMO, we had done a balloon arterial septostomy. And following day, we had to do mitral valve repair because mitral regurgitation was so severe. Then we weaned from ECMO within 10 days of admission, and we had follow-up with same patient at 14 months of age, and he has been doing very well, including development. This is the ECG of same patient. This is one of the echo picture of same patient showing very enlarged left atrium with mitral regurgitation and poor left ventricular function. Patient 2 was term baby born by emergency cesarean section, was found collapsed at 11 hours of age. Again, blood was showing metabolic acidosis. Troponin 1 was elevated, that is one of the indicators of myocardial injury. ECG showed Q wave, ST elevation in lead 1, basically ECG showing anterolateral infarction and posterior extension of the infarct. Again, echo revealed impaired Y ventricular function and a dilated left ventricle with a paradoxical septal motion. Interestingly, a clot was found in ascending aorta, occluding left coronary artery. That could be the reason for myocardial infarction for that baby. Again, we started on ECMO within 10 hours of admission, and the patient was put on CVVH as well because of the fluid overload and poor urine output. While patient was on ECMO, because without taking that clot, patient cannot survive. So we supported the patient with ECMO, and while patient is on ECMO, we have done surgery and surgical removal of the clot from the ascending aorta was performed while patient is on ECMO. After that, patient showed improvement, and but altogether ECMO was continued for 86 hours. Again, on follow-up, he has been doing very well. This is the ECG of same patient, and this is the echo picture. That central white spot showing the clot in the ascending aorta, which is causing myocardial infarction.